starting now. Your patient is a 19-year-old female, and full case history is given to you with investigations. So we start with the case. To start with, we will be discussing only the first few lines, and as before, we stop in between and discuss the case and proceed. Don't get carried away with the investigations provided to you. Okay, so start now.
19-year-old female, a student, complains of low-grade fever with evening rise of temperature since 1 month, with occasional dry cough. Cough gradually increased, and 2 weeks back, she noticed a right-sided chest pain.
Wait a minute.
Pain.
So what is your thinking at this stage?
Sir, it is 1 month, so it might be a chronic tuberculosis.
Tuberculosis tops the list. Very good. What else can come like this?
Then empyema.
Empyema is something that affects the pleura. So why should the presentation be cough with expectoration?
Sir, intermittent fever, low-grade fever.
It can be anything. Pneumonia, 1 month pneumonia, maybe it's unresolved pneumonia, going for complications. Complicated pneumonia is possible. Yes, chronic bronchitis exacerbation is possible. Other chronic lung diseases with fever, what are they? Bronchiectasis, secondary infection is possible. So 1 month cough. Whenever you have got cough for 1 month, chronic cough, always 3 possibilities must be ruled out. One is gastroesophageal reflux disease. 2, post-nasal drip. 3, as we told last time, cough variant asthma, of course without fever. Cough alone, these 3 should never be missed. Cough alone. But you are given a scenario where there is fever also, so infection stops the list. Not only cough, there is infection also. And neoplasia, although rare in this age group, cannot be completely ruled out. Very, very rare possibility still remains. Hypersensitive pneumonias can also have fever. So cough can be a symptom of, as you said, tuberculosis top list. Others follow. Right. Then he developed right-sided chest pain.
Yes, sir.
What is that?
It might be pleural effusion.
Pleural effusion, does it produce chest pain?
Yes, sir.
Why?
Pleuritic type of chest pain.
Why?
Because of the irritation of the pleura.
No, in the beginning, when there is dry pleurisy, 2 surfaces of the pleura will be rubbing each other and you get pleural pain. As the effusion develops, the 2 surfaces of pleura are separated and you don't expect to get pleuritic pain. So in the pleural effusion early part, it is possible. Now, can this be pneumonia?
Long history pneumonia.
Pneumococcal pneumonia, pleuritic pain is the first symptom to appear. Early involvement of the pleura is very characteristic of Klebsiella and staphylococcal pneumonia. So late onset of pleural pain is not very favorable to the diagnosis of pneumonia unless it was complicated by poor resolution, lung abscess and secondary empyema, which is a rare possibility. Okay, where do you get pleural pain usually? What are its characteristic features?
Pleural pain is usually catching type of pain. Exacerbated upon inspiration.
Deep inspiration, very good.
The patient usually sits.
Where is the pain?
It is in the lower part.
Anywhere else? Can it radiate to? Can you get pain in the shoulder?
Yes, sir.
Why?
Because of phrenic nerve.
Diaphragmatic pleura irritates the phrenic nerve. C2, 3, 4. No? So you can have some amount of pain in the shoulder. Yes, that is also possible. Phrenic related problem 3, 4, 5. So that can be, there can be radiating pain. Yes. So this patient developed pleuritic pain later on. Yes.
She noticed right-sided chest pain. Pain
The-
increased on deep inspiration and coughing. This pain got relieved in 3 days, and since the last 1 week, she notices she is
So why did
becoming
the
breathless.
patient's pain got relieved? That you have to explain now. Why the pain got relieved? Pain got relieved. Why? The fluid accumulates and separates the two surfaces of the pleura. Very good. Okay. Then
Then after 1 week, since the last 1 week, she notices she is becoming breathless, which is worsening.
right. Okay.
Past medical history.
No, you said that the possibility. Now, what is your possibility in your mind?
mm, Breathlessness might be due to the
No,
pleural effusion.
total etiology.
Tuberculosis.
Tuberculosis. So, what other symptoms you want to ask?
Uh, for night sweats, symptom of any night sweats.
Night sweats.
Then any history of weight loss.
Weight loss. You want to know history of weight loss? Yes. Anything else?
Then
Do they eat well, or do they have anorexia?
anorexia.
Yes, weight loss, anorexia, night sweats may also be supportive. Okay. Past history,
Yes. No significant past
past
medical
family
history.
history,
So it is not given.
personal history.
So it is also not given.
So, what are the predisposing factors for tuberculosis? Commonly, when somebody has tuberculosis, what all possibilities that comes to your mind?
Lower socioeconomic status.
Lower socioeconomic status, yes. Overcrowding, yes.
Then um, any person with TB in the family.
That's right. Close contact, workplace,
Yes.
roommate, hostel mate, dissection mate, anywhere. Okay. Close contact, yes.
Then
Common things in the community. Diabetes,
immunocompromised people.
diabetes, patients who are on steroids, patients who are having retrovirus infections, immunocompromised people.
So,
Okay, so there is a susceptibility for tuberculosis. Whenever there is tuberculosis, you must always think: is this a diabetic patient? Retrovirus infection? Was he on steroids? Is there history of close contact? Yes. Anything else you want to ask, especially in the history of this patient? People with gastrectomy are well known to have tuberculosis. Laboratory workers, doctors, nurses, medical students are high susceptible categories of patients. You are in contact with them always. Patients cough to your face, relatives cough to your face. Okay, so anybody can
yes.
be. Anything else you want to know the history? You want to know about the immunization of this patient.
The immunization doesn't prevent infection.
What in fact? What immunization? What immunization? What's immunization in your mind?
So BCG is taken
BCG.
in the child.
Yes. Does it prevent infection?
No, sir.
No. Then why do you take it? Very good.
Sir,
Very good.
in the childhood, usually to prevent any complication of TB,
Like
if the TB, like miliary TB.
miliary. That's fine. Miliary TB is protected. Very good. Very good. Okay. What about the other vaccinations? Suppose you take mumps vaccination. What does it prevent? Measles vaccination. What does it prevent? Okay, what are the childhood causes of deafness? Childhood infections producing deafness.
Herpes zoster, measles.
Measles. So there are benefits. Okay. Although there are no, so it's mandatory that whenever you think about infections, you must always ask history of vaccination. Okay. Right.
Yes.
Now you
Yes.
carry on.
Okay. On examination, there is no pallor, no icterus, no cyanosis,
No
phlegm,
pallor,
no
no icterus,
lymphadenopathy
no
or edema.
lymphadenopathy, no edema. Yes. Now, what are the markers for tuberculosis on
Then
general examination? You are thinking TB. What are
pallor
things?
might be present.
How does TB produce pallor?
Yes, sir. Pallor might be present.
Why?
Anemia of chronic disease.
Anemia of chronic disease. Yes. Any other cause for anemia? Hemoptysis is massive. Yes. It can produce. Any other cause for anemia? Anemia can be suppressive cause for the bone marrow. It can produce bone marrow problems. They may be eating less, and it's well known that when you have tuberculosis of your intestine, malabsorption takes place. Which part of your intestine is affected by TB? Commonly, of course, you have got what's called peritoneal TB, intestinal TB, so lymph node in the TB, ileum. So which nutrient is absorbed from the ileum? That will tell you the answer.
Vitamin B12.
B12. So you can have B12 deficiency, and then you are using different types of drugs for TB, which can produce anemia. Tell me one drug, anti-tuberculosis drug producing anemia. What are common anti-TB drugs?
Isoniazid.
Isoniazid. Okay. Tell me how does isoniazid produces anemia? Isoniazid produces B6 deficiency and you get sideroblastic anemia. Okay. So don't just ignore anemia. Anemia can be a problem. Yes. Yes. Then
Lymphadenopathy can be seen in such patients.
Lymphadenopathy may be seen. What are the characteristic features of this lymphadenopathy? How to differentiate it from acute suppurative lymphadenitis?
These are matted lymph nodes.
Matted lymph nodes, yes. Suppurative lymphadenitis versus tuberculosis lymphadenitis. Basic differences.
Suppurative is tender lymph node.
Very, very tender. Very, very tender.
Yes.
That's the point. Very, very tender. Okay. So lymph nodes are to be examined. Very good. Very good. Okay. Then what are the markers in the general examination for TB? What all things you look for in general examination?
BMI might be less.
BMI may be less. Yes.
Then the person wasting may be present.
That is okay. Emaciated. Yes.
Yes.
What are the allergic manifestations of tuberculosis protein? How do they manifest? You are fresh from ophthalmology, so you will be knowing what's the TB manifestation in the eye. How does it manifest in the eye? Have you heard something called as flicten?
Yes, sir.
Flictenular keratoconjunctivitis is the answer. Okay. So what do you look for in the skin? Allergic manifestation. We have discussed that earlier. In detail we discussed it. Including histology we discussed. Erythema nodosum. Where do you get erythema nodosum?
In the fingers.
Shin. Oh dear. Shin and the forearm, back of forearm. Classical side there. Not in fingers. Oh dear. How did you come to fingers? Okay. Nodular lesions, erythematous in color. The third thing you look for is the BCG scar. Where look for BCG scar, Chaitra?
In the deltoid
Insertion or origin?
left upper arm.
It's insertion or origin?
It's the left upper arm.
At the insertion of the deltoid or origin of the deltoid?
The muscle bulk.
Muscle. So it's a intradermal injection. Okay, so you know where it is given. So BCG scar has to be looked for. So TB can have a marker, but can TB affect skin basically? Is there anything called TB of the skin?
Yes, sir.
Yeah, well, tell me types of TB involvement. Have you heard anything called tuberculitis? Scrophaloderma?
No, sir.
No, sir. Okay, there are skin manifestations. TB can affect the skin also. There are very few organs where skin TB cannot be the cause. TB affects almost all parts of the body. So there can be manifestations. And the eye, of course, somebody is suggesting choroid tubercle. That's only when you see the fundus you are able to see choroid tubercle. That's possible. Okay. Yes, go ahead. Blood pressure.
Blood pressure is 110 by 70 millimeters of mercury.
Okay, fine. One day when you went to examine this patient, the blood pressure is only 80. Nurse is panicking. What is happening? Till yesterday it was 100, 110. Today suddenly drop of blood pressure. What is happening to this patient? Known case of tuberculosis. Suddenly drops the blood pressure. What will you think? Cavity, hemoptysis. Wrong answers are coming up. What will you suspect? Adrenal involvement, adrenal crisis, Addisonian crisis. So that is how it manifests. Okay. So Addisonian crisis requires specific treatment, immediate attention. So drop in blood pressure is important in this patient. Yes, carry on.
Respiratory rate is 24 per minute.
Okay.
Then respiratory system examination. Trachea is shifted to the left.
So other findings we expect to be normal. So what are the causes of shift of trachea to left side? Tell me causes on the left side first.
It's the same side or opposite side?
You told they shifted to the left side. What are the causes on the left side that can make the trachea shift to left side?
Okay, sir.
Collapse, fibrosis. Both are possible. And what are the causes on the right side? Pleural effusion.
Then
Pneumothorax. Very good. So you got few differential diagnoses in your fingertip now. Okay, right. Then
right-sided chest movements are reduced.
so what are the causes of right-sided chest movements?
Pneumothorax.
So pathology in the pleura or pathology in the lung. So left side pathology is not possible in this case. It is right side pathology. Okay, then.
Yes, sir. Then percussion.
In a case of pneumonia, can you have shift of trachea to the opposite side?
So it is usually central.
That's what I'm telling you. Usually it is central, but is there a chance that it is shifted to right side, left side? Can a pneumonia patient develop pleural effusion?
Yes, sir. Pneumonia.
It can. Can a patient with pneumonia develop pneumothorax?
Yes, sir.
How? How? You can have what is called as staphylococcal pneumonia, which is well known to produce pneumatoceles, and it can burst producing pyothorax, pneumothorax, pyopneumothorax. Rare possibility, but that is possible. Right, then.
Okay, sir.
Then
On percussion, there is anteriorly stony dullness till the third intercostal space on the right side.
okay, and
Right axillary stony dullness present, and right infrascapular stony dullness present.
listen. So, what do you think is all due to?
So pleural effusion.
So, what are the terms used to describe percussion findings?
Um, Resonant,
Resonant, very
dull,
good. Dull.
then impaired dullness.
Such a word is not there. Such a word is
Impaired
not there.
dullness.
No. Dull,
Stony
resonant,
dullness.
stony dullness. One more word is there.
Hyperresonance.
Hyperresonance. So four terms are there. So here it is stony dullness. What does it mean to you?
Stony dullness indicates pleural effusion.
Okay. So the four terms I told you, dullness, stony dullness, resonant, hyperresonant, is as per our clinical method we follow in Amela, Hutchison and McLeod. But if you read other clinical methods, there may be words like impaired and other terms which is not used by us because we are not following those books. Okay, if any examiner comes and asks you why it is impaired, you just don't argue with them because these are not internationally accepted terms. Either it is dull or resonant, that's all. Okay, if you say it's impaired, that means you are hesitant to commit either way and you are not definite about your finding. So it should be clear terms. Okay, tell me some conditions producing dullness.
Um, new,
First tell your causes in the pleura.
pneumothorax.
What? Dullness.
Consolidation.
Pleura.
Pleural effusion.
Plural cause I am asking.
Pleural effusion.
That is very stony dullness. I am asking cause for dullness only. So pleural thickening. Pneumonia. Okay, pleural thicken the pleura, lung pneumonia, mass lesion. Yes, you wanted to ask some doubts. Please ask. Okay, you ask.
Hemothorax.
Hemothorax and pleural effusion findings are same. Stony dullness. Okay, no difference. Pyothorax, same finding. Stony dull. Liquids of any nature is dull. Stony dull. Okay. So lung parenchyma diseased, air gives the resonant quality to the lungs, and when the air is lost and it's a consolidated structure, also fibrosed, you may get areas of dullness. So absence of air makes it dull, right? Okay, and stony dullness you think it is all fluid. Now collapse you can have dullness. You are right. Collapse can have dullness. Again the same meaning. There is no air. So lung tissue, that's why it is dull. So if you palpate this patient for vocal fremitus, what do you expect to find?
So it will be decreased.
Decreased. So what are the situations where vocal resonance is decreased? Yes, what is vocal resonance? By what is vocal resonance? How is it produced? Vocal fremitus, vocal resonance. How are they produced?
It is the transmission of sound.
Where is sound produced from? Where is sound produced from?
Means breath sounds.
Is it breath sound you get here vocal resonance, or you have larynx? Which part of the larynx? Vocal cord, yes. Vocal cord makes some sound. Then it is transmitted along the bronchial tree. Then what happens?
Then we listen it through the chest wall.
Chest wall. You listen it by chest wall. Is it modified?
Yes, sir.
It is modified. It is modified. Okay. When this modification does not take place, it becomes loud. If the media through which the sound is passing is not conducting the sound, again you can have problem. When the two different medias then transmission becomes problem. You get dullness. So here you have
Yes.
stony dullness. What does it mean to you?
Because of the fluid in the pleura, there is no transmission of sound.
Is it
No
a
transmission of sound.
encysted fluid or is it a free fluid? Is it pleural effusion or is it free fluid or a encysted fluid? Why do you say it's a free fluid? Why do you say it is not encysted? Because you said the on percussion axilla is dull, and when it comes to the anterior part and posterior part, it is level is coming down. So it is a Ellis curve. You said up to third space it is resonant on the anterior part, but axilla is dull. Am I right?
The dullness in the third intercostal space.
Anteriorly, and axilla
Axilla also dull.
axilla is higher up in the laterally. So this is the peculiarity of pleural effusion. It goes up in the axilla and comes down. Back, where is the dullness? Infrascapular area. Am I right?
Infrascapular.
But if it is a free fluid, this fluid takes this shape of Ellis curve. It is minimum at level of backward and go up to the axilla and then comes back downwards. Okay, this is called Ellis curve, right? So this tells us that it's possibly a case of pleural effusion. Where is the apex of this patient? Apex beat.
It is not given, sir.
It is not given.
CVS
Okay.
is normal.
CVS is normal. So apex beat is not given. That is one problem. Apex beat is not given. Do you get shift of apex beat in pleural effusion, or do you get shift of the trachea in a pleural effusion? Which is shifted?
Trachea is shifted.
Trachea shifted. Trachea represents the upper mediastinum. Apex indicates the lower mediastinum. So when there is a limited amount of fluid, only apex beat will be shifted and trachea will be in normal position. When the fluid quantity increases, both the trachea and the apex beat shifts. But here it is significant enough that both has shifted. So there is no doubt about pleural effusion. Now tell me, what is the cause?
Cause is tuberculosis.
Yes.
Inflammatory.
Can this be CA bronchus, CA breast with a metastasis? Is it possible? It can produce cough, it can produce breathlessness, it can produce fever. Yes, can it be? So it is essential. Age is no bar actually. You get young also, CA breast and all. Malignancies are possible in any age. So always look for breast in females. Okay, and females also, the ovaries can have problems, can create problems to your lungs. So keep your options open always. Always palpate the breast and see to that that is ruled out. Otherwise you may miss the diagnosis. Anything else in general examination will be of help to make a diagnosis of pleural effusion. If I tell this is a case of rheumatoid arthritis with a pleural effusion, will you agree or not?
Other features of rheumatoid arthritis must be present.
That's right. So joints must be mentioned in the general examination. Once you have examined this patient, you find pleural effusion, you must then say negatives. After making a diagnosis of pleural effusion, I look for the following causes. There is no deformity suggestive of rheumatoid arthritis. Can this be SLE? Another cause of pleural effusion.
No other system.
Pardon?
No other system involvement.
Involvement. Features of SLE are missing. Can be hypothyroidism producing pleural effusion? So you must say thyroid is not enlarged. There are no features of hypothyroidism. Can this be congestive heart failure?
No elevated JVP.
That's right. So that should be negative. That should be negative. So autoimmune markers like vitiligo, raised JVP, deformities. So extra things must come in to tell that this is possibly of tuberculous origin. Okay. So carry on.
Now investigations.
What are the investigations you actually want? Tell me investigations you want.
CBC, hemogram.
Hemogram is normal.
Then LFT.
ESR you want?
Yes sir.
Why?
Chronic disease, it will be elevated.
Tuberculosis you expect to be very high. No? Why do you want RFT in this patient? There are many tests available now, but that does not mean you do all the tests for all patients. Why do you want RFT in a case of pleural effusion? So first investigation is hemogram, second is saying RFT. Is it? So what's the next investigation of choice? Next investigation, X-ray test. What do you expect to find?
Pleural effusion, there will be Ellis curve.
Ellis curve is not seen in the X-ray. There may be. The opacity. What's the peculiarity of the opacity? Uniform opacity will be seen. What is the peculiarity? What's the peculiarity of the opacity? Opacity, if it is pleural fluid, it will obliterate the costophrenic cardiophrenic angles. So minimal effusion obliterates the costophrenic cardiophrenic angles. Subsequently it goes up. Ellis curve phenomenon is seen. It is never horizontal. It is never horizontal. It is Ellis curve. That means as you look at the X-ray, laterally the opacity will be at a higher level than the medial part. So you may see rest of the lungs may show evidence of tuberculosis. There may be findings in the other side of the lungs also. That's why looking for pleural effusion. What's the next investigation of choice?
Suspect TB, ADA levels.
No, you have to aspirate the fluid. Pleural aspiration. Sputum smear for AFP is a very good suggestion that must be done. Yes, fluid you aspirate. And what do you expect to find?
Lymphocytes mainly.
Will you look at the color of the fluid?
Appearance is usually amber colored.
It can be colorless, it can be amber color in tuberculosis. Suppose it is white in color, what will you suspect? Chylous effusion. If it is red in color, what will you suspect? Hemorrhagic effusion. So it can take different colors. Straw colored, it can be milky, it can be hemorrhagic. What else will you do with the fluid? The fluid we obtain in this case is straw colored. What will you do?
Microscopy and then culture.
A microscopy, 100% lymphocytes. Biochemistry, what do you want to do? Biochemistry.
Look for any autoimmune diseases such as rheumatoid.
Oh dear. Would you like to know whether it's exudate or transudate? Come on.
Yes, sir.
So what will you do?
Look for LDH levels.
Look for protein content. Protein content is looked at. The protein content is more than 3.5 grams percentage. It is exudate. If it is less than 2 grams, it is transudate. In between 2 and 3.5, we will not be very sure what it is. In which case, you will apply Light's criteria. What is this criteria?
Light's criteria states that exudate is likely if any of the three is present.
What are they?
That is pleural fluid protein, is to serum fluid protein, that is more than 0.5.
Very good.
Then pleural fluid LDH is to serum LDH more than 0.6.
Yes.
Then pleural fluid LDH more than 2/3 of the upper limit of normal
Very good.
serum
Very good.
LDH.
Okay. So why do you want to differentiate between a transudate or exudate?
Exudate usually inflammatory causes are present, like infections, malignancy.
So you are going to the mechanism of pleural effusion. So the mechanism you said is malignancy infection produce what? Transudate.
Exudate.
Exudate. So the causes can be inflammation or infiltration of your pleura, like infections or malignancy. That's very good. What else can be the cause of pleural effusion? Mechanism.
Transudative, that is increased hydrostatic pressure.
No, in transudate, it can be because of excess amount of hydrostatic pressure, as in heart failure, can be, or it can be decreased oncotic pressure, as in case of hypoproteinemia of any cause, maybe excess loss through urine, nephrotic syndrome, or cirrhosis liver. It can be. So oncotic pressure diminution, or excess amount of hydrostatic pressure, or excess leak of fluid from the vessels of the pleura may be the cause, or inflammation of the pleura may be the cause. Depending on the mechanism, you can have transudate or exudates. Okay, so you want to differentiate. Once there are transudates, then you know the causes and you look for those causes basically, and if you are exudate, you look for the causes. In between, you said you wanted to see the glucose content. Somebody uses glucose. Why do you want to check the glucose?
Sir, glucose will be decreased in infections.
Like empyema, yes, it is decreased in case of rheumatoid fluid. So tuberculosis also it is decreased. So we want to know whether glucose content is decreased. That is a good suggestion. Yes. Anything else you'll do with the fluid? What about the cells?
Cells are mainly neutrophil predominant or lymphocyte predominant.
If it is neutrophil predominant, what you will make out?
Because of any acute infection like pneumonia.
Empyema basically. When the fluid contains a lot of neutrophil called as empyema. And if it's tuberculosis, what do you expect?
In tuberculosis,
Lymphocytes are expected. And if they are eosinophils, what do you think?
Allergic.
Pleural effusion with eosinophilia, parasites of course, pulmonary infarction, pulmonary embolism, or trauma can produce eosinophilia. So cell count is important, and cells for pathological examination for malignant cells may give clue to the diagnosis. We may look for fluid for AFB. Now we have got devices to look for AFB. Okay, so you can look for AFB. 90% accuracy you may get AFB. Any other technique of confirming your diagnosis of tuberculosis? You may do a pleural biopsy. Pleural biopsy plus pleural fluid may give you the diagnosis in 90% of cases with good specificity. So you may do blind biopsy with a Brahms needle, or with a VATS video assisted thoracoscopy. You can find out irregular areas on the pleural surface where biopsy from that site may give the diagnosis of tuberculosis. So these days we can have diagnosis very clearly. It need not be always the presumptive diagnosis, but you can have evidences for tuberculosis itself. Yes. Okay. So once you have got tuberculosis diagnosis, what's your option?
Management.
I know, that's called management. When you are asked to say management has got two wings. Wing 1 is investigation, wing 2 is treatment. So investigation, you may check out for blood glucose, tuberculosis. Okay, retrovirus you may do. Then you go to treat this patient as a case of TB. So primary drugs are given for extrapulmonary tuberculosis. Category 1 treatment is given as per TCP guidelines, watching for the side effects. Now, if the patient is having, can this be a case of pancreatitis producing pleural effusion?
Sir, it is also X-ray so positive.
It is commonly on the left side. So pancreatitis commonly produces left-sided pleural effusion. Other conditions producing left-sided pleural effusion, predominantly left-sided. Congestive heart failure, to start with it is right-sided, subsequently becomes bilateral. Cirrhosis liver, to start with it is the right side. Meigs syndrome, again on the right side. Esophageal rupture can produce on the left side. So Jones-Jones is writing correct answer. Okay, it is on the left side. It can be rupture of the esophagus, and in which case which will be aortic dissection. Agreed, aortic dissection, yes. And which case, what will be the amylase content of the pleural fluid like?
So it will be high.
In which condition?
Pancreatitis.
Also, in case of rupture of the esophagus, it is non-specific, it can be high. So now you know left side diffusion, right side diffusion, and you know about the findings of end-sister diffusion, and you have got almost all causes of effusion: supradiaphragmatic causes, infradiaphragmatic causes, infective causes, non-infective causes. So wide variety of conditions in your mind. Meigs syndrome in a female should never be ignored. Okay, rare things are there, but must be always be considered, especially when the history and findings are not supportive. Now, any doubt from your side? Differential diagnosis of dullness is consolidation, but he has stone in dullness. Consolidation does not take the Seldy's curve, and it will be confined to a particular area. Pleural thickening, other findings are not there. Okay, mass lesion again does not take this shape or findings. If this illness started as fever with cough, expectoration, subsequently pleural pain and pleural effusion, we would have thought about pneumonic effusion as well. Okay, simple pneumonic effusion, complicated ones, or frank empyema. All the three varieties are available, which case treatment is different. Now your doubts and questions.